We're going to start with our panel discussion. That's really the meat of this whole program today. We have 6 very brilliant individuals.
I think one of the biggest things we learned is that our public health system needs some additional support, and being able to respond as quickly as possible to these types of pandemics, and being able to respond in a culturally responsive way, right? Specifically for the African American community and our experience with vaccines and the health system, it hasn't been a great one historically. And so our ability to be able to get out information and be able to support individuals in making a decision about whether to get vaccinated or not. What does this mask really mean? Does it really help me? I think learning how best to deliver information to individuals. We see the majority of the individuals that we serve are African American, but we have a large and growing Latino, Latinx population, as well as Hmong population. And so our ability to be able to respond in multiple languages in a way that's responsive, we learned we had to do that very quickly and utilize and lean on our staff to be able to do that. And we were kind of out front and waiting for, our public health to respond, our governmental systems to catch up to us. And so I feel like we learned that we just need to step out and do what we feel like is the best thing for our communities and be okay with that. But also being flexible in allowing communities to make the decisions in their time, especially because of the historical trauma that has been for a lot of our communities of color. And so around safety, just putting yourself out there, right? I got my mask on. This is how you put the mask on. This is what it means. Hey, I've got a mask. I know it's uncomfortable, but also, practicing social distancing, or physical distancing, not social distancing. And then trying to use the technology that's available to help people get through, to stay safe. Then some things that we learned and tried to implement as quickly as possible, specifically for our staff as well as our community, because our staff is reflective of our community. So a lot of the messaging and things that we needed to do, we used our staff to make it happen. And we were able to get a good response from our communities and showing up and wearing their masks when they were in our facilities and things like that. So
one of the things I would say that we have learned in our so Native American Community Clinic in South Minneapolis primarily serves about 75 to 80% of its client population is Native, from a 1 to 3 mile radius of the clinic. So pretty South Minneapolis centric, although we do serve people from all over the state. We have people who drive all the way down from White Earth, Boys Fort, all the way to the Twin Cities to see a provider. Couple different things I think we learned. One is that there was we expected that the pivot to telehealth would be a significant challenge, not for our organization because we'd already been sort of like playing with it and testing it out the year prior to COVID. We were looking at building out the capacity to do telehealth. So our pivot was fairly rapid, which was great. But I think we had some expectations that the community would have a lot of ambivalence around it. But surprisingly, at the sort of like the most critical point of the pandemic in the early part of the winter last year, 2020, we were able to successfully get folks to sort of pivot and move to telehealth fairly rapidly. All of our behavioral health programming went to telehealth practically overnight, and folks accepted that fairly well. Medical as well. Our dental operation had a really difficult time with that pivot. Obviously, it's really hard to do anything dentistry wise with telehealth. You kind of sort of need to actually have physical space and an open mouth and somebody actually with tools doing things. So that was a challenge, and we have been able to do that fairly well for the last year. I think one of the other things we learned is that the needs of the Indigenous community or the Native American community in South Minneapolis and the urban core have some different needs than the sort of the outstate, the tribal and rural communities. Not significantly necessarily different, but there's access issues that are different for the for the urban core than is true for the urban folk. I mean, for the rural folks. I think people sometimes mistakenly perceive or think that folks living in an urban environment should have access to technology and internet and all these other kinds of things that you assume is going to be more accessible and more stable than in a rural community. But folks in South Minneapolis had a lot of challenges with technology, not just for healthcare, but for school and a bunch of other things. So that was really challenging for our community in lots of ways. One of the things we learned actually with the COVID vaccine rollout, though, is that tribes and organizations like ours that were given the latitude to be able to decide how and who to prioritize in terms of vaccinating our communities, that we rolled that out fairly rapidly. We got that that opportunity to engage that way because of our government's understanding, our leadership in government, their understanding of our sort of relationship as Indigenous people, our sovereignty. And, we knocked it out of the park fairly early. We were doing as well as some of the larger health systems in terms of identifying and getting the vaccine to people as rapidly as we could in the early parts of the rollout. And that speaks volumes to what is achievable when state government and public health systems and those things partner in meaningful ways with community led efforts to respond to a health crisis in their community, because we are the people that know our community best, right? And so having those meaningful engagements with folks on the ground doing the work in community is really important. And I think that's a really important lesson that that our state health system has learned, and hopefully will inform how we move forward in the next several years. This certainly won't be the first and last pandemic we face, probably.
Anthony, I'd like to tag on to that and actually bring May in for a second. One of the things in preparing for this event was a comment from panelists saying, listen, we always seem to do the same thing over and over again. But there really has been a lot of work that has been done. And Anthony mentions it. A distinction between metro and urban messaging needs to occur. The recognition that each of the, not only panelists here, but many, many agencies and community leaders who know their own community need to be part of the systems, not just check the box, like, okay, we fulfilled this activity paid for by government dollars, but really sitting at the table. And that's part of what this convening is about today. We're sitting at the table. May, thoughts on that?
Yeah, I would say maybe just talking about sitting at the table to define what that means. I think for so many, I'll just speak specifically for me. Sometimes, individuals want our opinions and they don't compensate us for it. More importantly, they don't acknowledge us for it. And then I would say something else is just not seeing the results of that. So many times they want all of these ideas, but the reality is somebody else is already making the decision. So one of the things that Lillian, that I sort of talked about with you was, as much as wanting to bring us at the table, be really clear what you're trying to achieve and be really clear about the things that we can't change. And if we can't change, tell us why and how we can change those systems. So I think that that's really an important piece. I do think that we often bring the same people to the table, and within so many different communities. Again, I'll just say within like the Hmong communities, some of our elders, they are the wisest. They are the ones that should be sitting at the table, not the one with a PhD, right? Or however, because of their formal credentials. So I think, again, as our state and as, again, solutions are being created about what's next, I want to make sure that we're including, again, our elders, but also our youth populations, that, again, it impacts everybody. So I would say that's probably most important. And I often have seen there's so many individuals that are wanting ideas, but then I never know what happened to them. It's like, so what did happen? What was the decision? And so as we're sort of thinking about sort of what's next and what we want to do next, let's make sure to be really transparent And I think that's the other piece is accountability, transparent. If you are taking individuals' valuable ideas, making sure that there is specific follow-up. And again, you're not going to the same individuals, but you are being inclusive and thinking about bringing others to the table. So that's the piece that I would say about, let's make sure that, again, the normal wasn't working for everybody and it continues to not work for everybody. We were certainly seeing that in the unemployment rate, women being out of the workforce, the mental health crisis that is happening now. So let's make sure we include those populations and have real conversations. And then something else that I would also maybe ask us to think about is think about the nature of trust building. I think how we build trust with different community looks different. And so I think that's some work to be done there as well, is really, again, really supporting our communities that way.
I would like to add that the trust is very important for especially our community, Somali community. You know, the Somali community, they kind of been confused on the not understanding about this COVID-19 pandemic. And also the other thing is there are not enough Somali health professionals in the healthcare system and to trust. So many of them, when they've been sick, they are avoiding going to the hospital because they think they might die there. They won't find any empathy to their cause, and they won't find anyone to listen to them. So they feel the kind of being really apart and not part of the community, because they think they are people of color. They think they are immigrants. They think they are also Muslims. So, and they don't know really who to trust. So they are really very careful. So what we need to do is really to engage, to listening, and to integrate their community health professional. And that way we can build more trust with our community. And especially with the vaccination, we can see, because Somali community, they were really very distressful with the vaccination in the past, especially when it comes to measles vaccination. So until now, the pandemic, and we have a lot of misinformation on the social media, and they're really very careful, they're resilient, and they really would like to hear and listen to their professional so they can trust. So we know our culture, we have leaders, cultural leaders, religious leaders, we have also professional leaders. So those people are the people really our community trusts a lot. So we need to engage these people, and we really to sit on the table, because our community feel that they are a little bit behind. They are been not listening enough, and they just being like hard worker, but not part of the decision makers. So I would like to really emphasize on the trust. There's not really a lot of trust that we need to build on. And we're talking about inequity and disparity a lot in the past, but now we can see with this pandemic what's going on. So we need really to work on that.
Dr. Aiden, I was going to add to what you were saying too, because on top of the trust, one of the things that I've noticed is, again, well, with the COVID, again, while that's free, many people of color do not have health insurance. When they don't have health insurance, some of the impact of that, again, not knowing how to navigate the systems within healthcare. So again, if something happens, how do you navigate that? And so again, back to your point of the importance of building relationship and transparency and accountability and asking for community participation and engagement, I think is going to be critical for us. And I don't think that we're doing that enough. And when we do, again, we seem to be going to the same people. So again, who's at the table and why?
And to recognize the people are going to change, right? It's not the same people all the time. We have to grow with communities.
And I feel like one of the earliest, biggest one that we learned, if just in case that if we haven't learned that disparities and racism kill, this time around, I think it was in our face. And if we don't take that message, like when you combine one pandemic with the other pandemic of racism and disparity, like it's called like a syndemic, how it killed, how we were able to see a map with the death about where are existing inequities. If we don't take the opportunity to learn, we are not going to to learn it anymore. We knew part of the pieces that we were talking about that here, right? We knew how to do the search towards the hospital, right? I remember during the first months, you all probably remember the search, how to search and expand the hospital in the hospital. But we didn't know how to expand our reach to the community. And we were lost in many, many systems. Like, how do we communicate back to the community, to those that are not in the hospital, to protect them, for them not to come into the hospital? So that was a tremendous lesson learned. And that piece, I think that we learned that primary care is essential, and we shut it down. Because if we were having pieces of primary care standing up, it probably will be like an amazing differences. And we learned that in Akiparati because we were the only clinic during the whole pandemic that we didn't shut it down. Because we were coming from 5 years of pandemic hate. And we were just grappling ourselves with numbers, like in our community, in my clinic, there was a surge of anxiety in our teams that increased like 3 times the level that we have anxiety among teens for the last 15 years, since 2007. So in 2015, we saw like an increase like 3 times, an increase of family separation 8 times. So, and it didn't take a genius, right, to know like teen mental health, it's going to crash. So we didn't close March 16, and we became like somehow of like guidance for the whole hospital about what was going on with the families. And families were telling us like, you guys are calling us? We thought that we were going into the house just to protect ourselves, and our fear was like, now what? Who knows if we die? So primary care, we needed to save some pieces of primary care open to guide the communication with the community and to learn from them, what do you need? Cell phones, lifesavers, like people sometimes they don't have computer, but everyone has cell phone, including the Latino community, reason why you see the commercials in Spanish, because they're like the biggest user of cell phone. So, well, shouldn't health insurance pay sometime for the ability for their line, thinking about like this is access to healthcare through their cell phone. Learn, we talked about this around this, all the panelists touch on this, but we need to learn how to actively listen to the different, to the one who have an accent, to the one that the skin color is different. Don't have them at the table because that could be a token, right? But make a plan about how are you going to really, really listen and show to that person, like you put that action, that plan, that idea into action. I will not say like for the first time, but this was really clear. Like when you count people in the community, everyone is part of the community. And if you don't have access to healthcare, who cares? You are going to have an impact. That's what I mean, okay? You're going to have an impact on the health of the community. You have access to healthcare or not, which I think it's the biggest lesson. It's like we need universal healthcare, regardless if you're documented or undocumented, because you're going to be impacting the community no matter what. You are already contributing for the goodness of the community. But if you get sick, unfortunately, it's your family and the rest of the community that will suffer.
So I think one of the things that the pandemic taught us, and this is certainly true, probably absolutely true about Minnesota, it's probably true about the nation. One of the things that the pandemic taught us was just exactly how pervasive institutional racism is within all kinds of institutions, certainly within healthcare, but also across the board in all kinds of ways that actually create all kinds of inequities that make Black and Brown and Indigenous folks and immigrant people very vulnerable to something like coronavirus. But we've had vulnerabilities way before that. And so what happened is the pandemic laid all of that bare, right? Stripped it to the bone so that we can see actually the structure, the skeleton is problematic, right? The same issues that are systemic that lead to some of the challenges that we had with COVID-19 are the same issues that are true about public health and public safety, that have led to the reasons why we have one of the highest homeless rates in the state, and why the amount of homeless people that this state has is among Black and Indigenous communities. And those folks were the people that were significantly vulnerable during this pandemic. They had practically no access to healthcare, no access to testing, no access to vaccines, those kinds of things. And they were not by and large being served by smaller health systems and larger health systems, right? And so we have an opportunity to have to learn from this lesson, and you know, in the words of Uncle Joe, build back better, right? So you know, as we think through, like, you know, our state is getting a significant influx of infrastructure dollars to sort of respond and help communities build back better. Let's take this opportunity for, as lawmakers, policy makers, as decision makers, as providers, as, you know, as every one of us that contribute to a system that provides care for our communities, to think innovatively about how we solve the larger issue, which is some real structural sort of change needs to happen, shift here with respect to how people gain access to resources, human, financial, and otherwise.
Perfect. Thank you. I love that. So building back better. I love that. And using innovation and creativity. I'm also hearing a theme on inclusion. So on that, I realize that for some folks, the pandemic may have been easier than for others. So I think part of inclusion is understanding how the pandemic can affect others. And one piece that I would like to also touch on is mental health. I think, Anna, you know, you've with your leadership on mental health, are there maybe a few perspectives that you'd like to share?
Sure, thanks. I wanted to build on what Dr. Stately was saying, because I think that's something that we learned and something that we need to address as we move out of COVID. And that's that context of, you know, the connectedness, that everything is connected. This isn't a new lesson for public health. But I think it's something that we are still learning, like how to do that. I think we need to, you know, like the individual and collective traumas that we experience, they feed on each other, and they build on that unresolved historical trauma and current trauma that we have. And we have to learn how to more effectively work across issues, right? Like pandemic, police violence, climate change, all of these things are interconnected. And, you know, the common thread, I think, across all of those is equity and mental health and well-being. And we have to figure out ways to work across issues and not in silos, because these aren't separate issues. I think that's maybe a lesson learned, or something that we'll continue to learn as we move out of COVID. And then just from a mental health, like a global mental health perspective, I think one thing that we learned, so kind of going back to the first question, but maybe it's still a need, is that there's really a lot of work to do to promote mental health and well-being. I think we talk a lot about mental health, but we don't always practice it. And I think we recognized in COVID that mental health is something we all have, and we all need more capacity, right? Individuals, families, organizations and institutions and communities, we don't really practice mental well-being very well. We need more skills and capacity to do that. And so I think that's a big need. And then, like, something I like to highlight, because I think they're under-tapped opportunities that I think we really learned in COVID, was that that a lot of research and a lot of communities and cultures already knew, but maybe didn't get the attention that it did. And that's that simple things like social connection and access to nature. Those are really important, valuable strategies for our health and well-being. And so how can we build on that? And and advance those things so that they're just more, we don't have to talk about it next time we have a pandemic or next time we have a community crisis. Those are things we can all draw from. So
Absolutely.
I don't know if that answers your question, but that's
Yeah,
Some of these
it does. It
ideas,
does.
some of these ideas that you're talking about and you're mentioning, the communities are actually already doing for each other and for themselves. And I think, again, bringing them into bringing each different type of culture into the workflow is really might be part of the recipe. That's going to take time and it's going to take money, because we can't ask people to come to the party, so to speak, or invite them to be the party and not pay them, which is also another common behavior. It's sort of like, hey, let me ask for your opinion because I need something. I mean, we need to work with we and respect that work.
Yeah, this is definitely not a bring your own bottle affair. So I think
Right.
one of the things that I would say is the respect to that. So, and I think that my Tao might have some really good ideas about this. And I've been talking about this with leadership at the state and a few other places for a while now. As we move out of the pandemic, one of the things that we're going to find is that we are significantly under-resourced in terms of a behavioral health and healthcare workforce. We lost a lot of people. We lost a lot of that infrastructure during the pandemic. And quite frankly, I was thinking about how, Kimberly said, and a few other people have said, Dr. Aiden said earlier as well, that there was not a lot of representation of Indigenous, Black, Hmong, Muslim and Somali people within the workforce already. And certainly what happened as a result of that is that we have even less of that now. And so part of, I think, building back better is recognizing that, we were about 10 years behind where we needed to be in terms of having an efficient and successful workforce for health and behavioral health before the pandemic. Now we're probably about 15 years behind. And so what I want to encourage leadership at the top of all of the government agencies, and also our governor, people in our state legislature, to invest in replacing those individuals. We need to have a stronger health system, not just now, but for the next time go around. And we need more BIPOC people in healthcare. And so investing in that and doing a really good job of that will help us do a better job the next time. And, the reality of it is there's an indigenous concept here, like this idea of homotakios and how we're all related. Like that's what the pandemic taught us, was that my livelihood and my health, my well-being, and my very life depended not just on me, but also on you. And a lot of people that I didn't know, right? Mm-hmm. So remembering that concept and thinking, how do we sort of operationalize that, and everything that we do intentionally is really important here.
I agree with you in that our ability to recreate this pipeline of healthcare workers that actually reflect the culture and the heritage of people of color is important, in creating those alternative pathways that sometimes don't actually fit into the nice box. But I mean, at North Point, we utilize community health workers in a broad range of services and activities, and our ability to get them compensated through a third party payer through healthcare. We still making that battle, right? But those are the individuals who help our community make the behavioral changes necessary to address the disparity in obesity or diabetes or anything else. Like our community health workers on the front line of COVID, right? They're the ones doing the screenings. They're the ones helping people fill out the paperwork so they can get the shot, right? And they're the ones who are convincing their brother, mother, sister, aunt, uncle, grandmother, whoever, to come and get their shot. And so our ability to create a healthcare system that actually reflects the communities that we serve, and that the people who want to serve can do that without having to take on a lot of debt, without having to be in school forever, but they're bringing the cultural aspects of what that have been handed down from generation to generation to take care of that particular disease or cold or whatever it is, but to also have that connection to that community and each other, to be able to provide that service and to build a community within that within our healthcare systems that actually can help to address disparities. That's the part I'm excited about working at North Point, because we have the ability and we're seeing the gaps in our pharmacy techs and our MAs not being able to get individuals to come and work because they can go to the hospital and make more money. But then we have staff who may not have, graduated from high school. They may have a GED, but they're interested in those fields. But how do they get started and how do they get the support that they need to complete and get the certificate, to get the degree, to be able to come back to their communities that they love and care about and begin to serve there. I'm sorry, Anna, I didn't mean to cut you off. So go ahead. I'll pass the mic to you.
No, that's awesome. I guess I just wanted to echo that, but I wanted to add an and. I think we need to build that capacity of those like institutions, but I think I like to say we need to put the fluoride in the water. I think that was a gift from COVID, that we can't just have the messages and the services come from institutions, but we have to be that has to be from community. I mean, our institutions aren't designed to address these collective problems in efficient ways, right? Like we have, the mental health system is a great example. We try to treat institutional or racism in an individual way. It's a collective experience, but we try to make it an individual responsibility. And I think our institutions, our medical institutions, like, we need a different way.
Yeah.
So I agree, we need more providers from all backgrounds, but we also can't just stick with the same structure, right?
I think it's critical to disaggregate data. So I think some of the messaging has been the one size fit all. And if you're going to create solutions, make sure that you're disaggregating data and involving community grassroots providers or organizations that are already doing this work. I think that piece is going to be really important. I think the other piece is also to, as technology becomes more integrated in all of our lives, just again, the recognition that not everybody has technology or broadband, or again, the languages. Was it the phone when the vaccine was first available? I mean, thousands of callers were waiting on the call. It was all in English. So if you were calling the line and you didn't speak English, that didn't work. So those are solutions that, again, at the top, you're trying to do your best. You're rapidly creating solutions, but again, it's not appropriate. So I think disaggregating data, also not forgetting that there's a lot of anti-hate right now across the organization, and especially within the AAPI communities, and that there needs to be around that piece as well. And then I was just going to jump quickly to the workforce piece. I think the issue is actually part of it is that we're training so many people for entry-level jobs. The reality is you've got to build a pipeline for them to be able to move up, because they're working poor. They're working 3 to 4 jobs. They're the ones that are at the front line. And they also are living in intergenerational family households. So if I go in as a personal care assistant or whatever that kind of front line is, I'm bringing it back and I'm taking care of my parents. And so if something happens to me, and so I know specifically that those are things that we want to think about. Again, let's not just get people of color in the front door. Let's make sure we're building them into pipelines of leadership, authority, decision-making. And so that's where I think that next phase is for organizations to think about that. Because the reality is that when you're getting them in the front line, great, but now they have to have 4 or 3 different jobs just to, again, support their families. So again, just some things that I wanted to make sure we brought up about workforce, but specifically women because of their second roles and etc. So I think the complexity of this is not as easy as let's get them trained. Well, they're being trained for minimum wage job. That is not family sustaining wage. And once they get in, they're not able to move up. So I think those are things that as we are thinking about infrastructure, technology. And then I would just say the most important thing as we are thinking about this is the integration of technology in the work of the future and how that is changing and how are we preparing our communities for that, especially now more than ever with the labor shortage. So
I want to interject. We're getting some awesome comments on the chat here. I want to shout out to some of these individuals. Here's a quote: Relational trust takes time. That is so true. And it's important that we build and develop the relationships, not as one-offs or not as just at the table, so to speak, as a check the box move, but really do you have relationships in your Rolodex that you would actually call, not always because you need something, but because maybe you just want to learn or talk or chat. Somebody else commented about some of these problems that are going to take 5 years, maybe more, to overcome. I know that sounds monumental, but we have to pick away and chip away at it. And another person adds, these are hard conversations that BIPOC communities need to have, but across a variety of different areas, and we just simply need to do the work.
We create trust when we show that we see the others, their preferences and their values. And so far, part of what we have done on our healthcare is sort of like represents the values and preferences of it's whiteness all over, right? It represents the values and preferences of the main, like, of the white community. So it's compartmentalized, it's individualistic, and it doesn't incorporate those elements that when someone comes and offers me a certain process or a certain individual reflects my values and my preferences. And to the importance of disaggregating data, remember where we are starting to do this process, right? Like the recognition that because we were able to disaggregate the data around 20 years ago, we went from thinking that Minnesota was one of the best healthcare system in the world to the one with the widest healthcare gap in the nation. So maybe number 2 nationwide of how bad we are. And when we're thinking about, like, in order to generate trust, you need that cultural concordance of providers, right, that we were talking about. But I wanted to highlight something that May and Callie, we were talking a little, and particularly with Anthony, we are together in a different committee, and to remind everyone that Minnesota has one of the widest achievement gap in high school for teens of color. We are the worst for Latino community. And you may say that accent, right? We are the second worst for African-American community, the third worst for Native American, for Asian. So it's a pattern, right? So it's a pattern. We are the worst for the other. And I totally agree. Like someone was talking about in the panel about integration, about healthcare, and school for everything, particularly for children and teens. Healthcare and school needs to be like this. Like they need to talk and they need to speak. And when we need to be talking to them, and when you do that, most of my teens want to be pediatricians or family medicine or like it is out or psychology. It is mind-blowing. So when you are there talking their language, meaning their cultural values and preferences, they want to become part of the system.
Thank you. Thank you, Maria Veronica, for speaking so openly and so honestly about these things that are so important. I think that, we've talked about inclusion and representation, but it's even about understanding what does inclusion and representation mean. Is it about seeing people that look different? Or is it about, like May was saying before, really integrating their opinions, their wisdom, their perspective, so that we can really change things to be able to serve them better?
I was just going to say that some of the distrust within our communities is longstanding and historic, right? So it took us a long time to get here. We've had a lot of harms by state government and agencies that have, earned that mistrust. They worked, either through ignorance or actually sheer will sometimes. So the reverse has to happen, and it's going to take some time, but it has to be thoughtful and intentional and authentic. And then you start to earn the trust of those communities that you harmed back, right? The other part of that is recognizing, like we learned, is that, I want to give a shout out to community health systems here, which with community health centers, because we are the folks that are doing some of this work in our communities, and we have those relationships with our communities. Many of us are from the community that we work for, right? And we have been the brokers of this trust for a long time. So what we want to do is we want to make sure that people in larger health systems and or the state recognize the role that we have in our communities, that we're brokers of trust, and not to abuse us and not to misuse us, because that won't bode well for the
Thank you.
process.
Thanks, everybody. Look forward to the follow-up from these, and really appreciate your time and powerful comments today. Thank you so much.